Good morning, everyone. I am leading the final panel on treatment that will keep you from your lunch. After this is over, you will be able to eat lunch, or we're taking a break for lunch, I should say. So my name is Sarah Kawasaki. I am an internist and addiction medicine specialist through Penn State Health. I'm Director of Addiction Services at the Pennsylvania Psychiatric Institute, where I am Medical Director of an opioid treatment program. And I am an assistant professor of psychiatry and internal medicine at Penn State Health. So I wanted to introduce the panel that I'm working with. So let me see if I can recognize the people that are on the panel with me here. So if you want to introduce yourself, we should all introduce ourselves. Who wants to go first?
I can go first, Sarah. I'm
Great.
Brooke Hiltz. I am with the University of Kentucky's Healing Community Study, which is a NIH-funded study across 4 states. And I am a community coordinator for one of our Wave 1 counties and one of our Wave 2 counties, and also a community program manager overseeing all 16 counties that are part of the study. And so I'm here today just to add a little bit of the community engagement perspective and how we've tried to influence the treatment landscape as part of this one-of-a-kind study. Thanks so much.
I'm happy to introduce myself next, if that's all right. My name is Chris Cook, and I also work on the Healing Community Study with Brooke at the University of Kentucky, spearheading. I'm the manager of our treatment program. So I'm focused in all of the counties that we are currently intervening in, as well as the additional communities that will be we're moving into shortly, spearheading our efforts to increase access as well and linkage and retention in treatment for opioid use disorder. So I work in collaboration with kind of our 3 primary faculty that are all certified in addiction medicine that provide technical assistance and support to our communities. And I'm looking forward to talking about our intervention.
Good morning, everybody. My name is Mike Gersz. I'm the Director of Outpatient Services at Maryhaven. I live in Columbus. We're here in Columbus, Ohio. I wanted to wear my tie, my Ohio State Buckeyes tie, just kind of appreciation, but also a little jab at all the Penn State fans here. Everything you've heard about Ohio State fans is true. We like to wear ties like this, to present whenever we have an audience. So just wanted to share that. For those who don't know, which is probably most people on this call, Maryhaven, we are the largest and oldest behavioral health treatment provider in Central Ohio. We have services that span multiple counties. We offer, we're amazing. We offer basically all levels of care, all ASAM levels of care, including our detox withdrawal management, all partial hospitalization, intensive outpatient, general level 1 outpatient services. We have specialized opioid treatment, including methadone, buprenorphine, Vivitrol. We do all sorts of prevention work. With kiddos and youth and families. We also have gambling prevention and treatment. We have all sorts of criminal justice treatment, including Federal Bureau of Prisons, federal pretrial, federal probation, specialty drug courts, Franklin County municipal and Franklin County common pleas contracts. So you name it, we do it here in Central Ohio. Really happy to be here today. And so that is an introduction for me. Thank you.
Thank you, Mike, choosing violence this morning. And last, Anthony.
Hi, good morning. Tony Folland. I work for the state of Vermont, the Department of Health Division of Alcohol and Drug Abuse Programs. I manage the day-to-day clinical services for all of the alcohol and drug abuse services in the state of Vermont. I'm also the state opioid treatment authority, which in Vermont means that I have regulatory oversight over all of the opioid treatment programs, which in Vermont we refer to as hubs. I also have regulatory and clinical oversight over every Data 2000 waivered prescriber in the state of Vermont and have since 2011. And prior to working in the state of Vermont, I was the clinical director for the original buprenorphine induction hub, and it was one of the developers of the Vermont hub and spoke model. So it's nice to meet everybody, and thank you for having me.
Fabulous. It's wonderful to have such different perspectives on this panel. So I thought I'd ask a very broad question to warm us all up a little bit on how the pandemic has changed, either what you're doing clinically or what you are involved in policy-wise currently. So if we could start, maybe we'll start with the team from Kentucky.
Sure. Chris, do you want to start off on this one, or would you like me to take it?
I'm happy to talk a little bit, and feel free to interject other pieces that that you find. And so I will say that for everyone, it impacted, as we mentioned, we were kind of spearheading this intervention for the healing community study, and we got into our stage to implement the activities that we intended to try to increase access and linkage and retention right as the pandemic was kind of getting into its first wave. And so that certainly impacted a lot of our work. And I think in some cases it facilitated some of the work and certainly provided or posed some barriers. But I think some of the first benefits that we saw in some of the regulatory things and in implementation were really in removing prior authorizations and removing barriers to telehealth access and to PAs for Sublocade, for methadone from some of our MCOs and some things like that helped actually people be able to access treatment from some sources. But then, of course, we also saw a lot of barriers in the pandemic to treatment, particularly in what we were trying to implement in hospitals and emergency departments as they were overrun with trying to manage what was happening, from a pandemic perspective. So I think that as we've continued to go, we've seen a lot of progress, and we've been able to continue to have additional community resources come on as the waves have kind of continued, including we have now successfully been able to kind of implement some activities within our hospitals and our emergency departments, as well as criminal justice systems that were kind of in lockdown initially in the pandemic that we now have been able to make some impacts in. Brooke, if you'd like to jump in and talk about any of those specifically or others, please feel free.
Sure. One thing I would mention is just the access to treatment from a transportation or other wraparound services perspective. And so, one thing that I don't think we were anticipating is having to jump in and quickly address some of those challenges in addition to, we knew they existed, but the pandemic just exacerbated them and required a quicker response. And so we've been able to establish a barrier relief fund to really help address some of those wraparound services that were prohibiting individuals from either continuing in treatment or accessing treatment in the first instance. And so that's been a major effort that we've undertaken. Additionally, as Chris mentioned, that linkage and retention was a huge focus of the study. And that included staffing navigators and peer support specialists at treatment facilities. And again, because of the lockdown, we couldn't get that up and running as quickly as we would have liked. And so now. We're finally getting some of those things moving, but you certainly recognize that when there's a full stop to in-person care, in a lot of ways, that it definitely can negatively impact the ability to add some of those additional staff members.
We, at Maryhaven, we were probably conducting close to 0%, approaching 0% of telehealth prior to March 2020. And in a snap of a finger, we have to move to almost exclusive telehealth services, at least for our outpatient. Docs and NPs, we have giant residential programs, and with our detox, we had to pivot to, testing multiple layers of COVID testing for people walking in. We have walk-in services and access and placement to treatment, which has been really helpful. But at the same time, when you have that open door, you open yourself to a lot of risk. So we had to implement a lot of different safety mechanisms. Specifically, we had 2 large adolescent residential units, a boy unit and a girl unit, for years and years and years, upwards of 30 years. With children's services moving in and identifying kiddos at risk, our referral stream basically dried up in a matter of a few months. And we were running very large 24-hour-a-day programs with like 3, 4, 5 clients at any given time. So we made the very difficult decision to flip the units to adult units, which have been full since. 35-bed boy units are now adult units. 32-bed female are now adult units. And so that was a substantial shift in our service delivery. But we are able to still provide very high quality adolescent outpatient and prevention services, which has been helpful. Just not, we're no longer in the residential space. We are now, Columbus and Ohio in general. And I have to give a shout out to Dr. Magdalena Serta. Her presentation this morning was just absolutely phenomenal. She spoke my language through and through, coming from a harm reduction perspective. Absolutely loved it. Whoever got her on the line was really good. The prevention panel was incredible as well. Just wonderful, wonderful speakers. This is a top-notch lineup. Myself not included in that, just so you're all aware. But we've had to substantially change how we operate from a flexible system. We were very antiquated, having over 450 employees to move literally on a dime was very challenging. One of the things I'm most proud of, though, has been our partnership with Ohio Department of Health and Project Dawn. I don't know if Project Dawn is in other states, but we, provide, naloxone kits to the community and to our clients for free, which has been wonderful. So much to say, but that's it for the substantial, changes that we've seen since COVID started. Thank you.
Yeah, I would say as much as anything, we didn't switch what we do for business, you just switch how you do it. Risk stratification of disease transmission versus risk of lethality for folks in OTPs to ensure that folks who needed sufficient structure to make sure that they were being managed the best possible versus the risk of COVID disease transmission. We met weekly with all of the medical providers. We actually had all the medical providers at the OTPs come with a consistent, we facilitated a consistent methodology. We reviewed every patient basically at every facility so that there was a consistent processes in place. Residentially, we met with with our residential programs to make sure that they had a consistent disease transmission protocol and all of the COVID, COVID risk mitigation processes in place. So we didn't change what we did. We used the same opportunity, even in our emergency departments, to get our ED physicians waivered. So during the COVID period, we have all but one emergency department that now has a buprenorphine induction protocol with an off-ramp to our local treatment providers, where the treatment provider actually has appointment times sitting in the emergency department, paired with recovery coaches, whether they're there virtually or whether they're there in person, so that the recovery coach kind of becomes the facilitator that's checking in with them daily to make sure that the individual has, with all full transparency, knowing when that person's next appointment is, so that they are facilitating the person's making sure they receive to the next appointment, but the discharge is planned ever before the person leaves the emergency department and doses are on board. So we just didn't change what we did. We just changed and utilized how we did it.
And as a follow-up, I would just ask everyone, this past year, year and a half, has seen an extraordinary number of overdose-related deaths. And in spite of all this large amount of money and huge effort and hearts certainly in the right place, it really hasn't shifted the balance. Unfortunately, the pandemic has really upended everything. Has that changed maybe clinical presentation in any way, or what you're focusing more in terms of funding streams or policy? I guess I'll ask Mike first. Like, have you seen any changes in what patients are using or presenting with, or acuity?
That's a great question. Since we opened up our walk-in hours, we have Monday through Friday walk-in, which is extremely important for providing access to treatment. We never even anticipated how many clients were going to come through, double our expectations. And it's just a constant stream of clients, which is great for business, but at the same time, difficult to manage and unfortunate for the community. The state of Ohio was doing so great, 2019, early 2020, for mitigating overdose risk, and then that was just thrown out the window. And we are seeing a lot of trauma. We are seeing a lot of deaths. We've had 2 family members on our own team with staff who've had family members who have passed away over the last few weeks. Heart just breaks. It is everywhere. It is everywhere, all throughout our community. The rise of fentanyl has been just crushing here in Columbus. I'm very grateful to work on our overdose task force with the Dr. Ortiz, with our Franklin County coroner, and we've implemented a lot of really helpful ideas, a lot of helpful, collaborations to try to tackle overdose here in our community. And hopefully that's starting to stabilize. There's so many things that is going on. The federal government in the states, through SAMHSA, there's been a ton of state opioid response dollars, that we have been able to tap into for treatment, for recovery supports, for prevention, for education, for outreach, for staffing. There's more dollars probably than there's ever been. And we're just starting to scratch the surface on being able to see the impact there. One thing I do want to give a shout out for those who aren't aware, Anthony, his role, the SOTA of Vermont is an extremely important role. There's obviously a SOTA, state opioid treatment authority for every state. We work very closely with ours. And one thing that they were able to do when the pandemic came was to give more flexibility with take homes, to reduce the amount of foot traffic in our clinic, we had a historic DEA, OMAS, which is the Ohio Mental Health and Addiction Services, SAMHSA, the Ohio Board of Pharmacy. Everybody gave us all these tools, which we've been asking for and basically begging for. And unfortunately, the pandemic came, but it gave us more tools than we've ever had. And our clients were able to receive take homes and have access for services that they were never had the opportunity to do in such quick time frame. And what's happened was that after those take home exceptions were revoked back, so we had to just in one day snap back to pre-pandemic take homes. Everybody was up in arms. And I just want to give a shout out to our SOTA, but also Anthony, because our state opted back in to a new, more flexible take-home structure. My guess is Vermont did opt back in, but Ohio definitely did, something we've been asking for, because we are wanting our clients to integrate back in the community more quickly. And that's something we've been shooting for and something we've been asking for. So I'm happy to see, happy to see you and welcome. Anthony, nice to meet you, but I know how amazing of a work that you do over there. And I know what you're up against. That's a very difficult position. Thank you.
That was far too kind for, these days being a bureaucrat after being a 20-year clinician, but thank you. You're very kind.
I will continue the theme of buttering you up, Anthony. I can tell you that Pennsylvania needs to enact new legislation in order to change its take-home rules permanently. So and I have no confidence that something like that will actually be able to get off the ground. And our SOTAs just don't have the authority that you do. So.
I was just going to add, Sarah, from a community engagement perspective, one thing that's been really interesting to me, we're certainly seeing increased polysubstance use, which I think is across the board. But what was really fascinating to me as I meet with stakeholders across our communities as part of the study is it's almost an assumption that despite what the numbers are showing, that we have to turn our attention solely to methamphetamine or solely to these other substances, when the reality is there's still opioids that are contributing to these overdose deaths. And with fentanyl, obviously, that's a major piece of it. So from the study's perspective, we've also had to pivot in terms of our communication efforts on educating the community more on the rise in fentanyl and what that means. And so, you talk to a police officer or to a coalition and they're like, oh, our seizures are primarily methamphetamine. Okay, well, that's great. But if there's even a pinprick of fentanyl, that's what's killing people. And so, the rise of the pill presses and all of those things are just insane, as we all know. But from a true community engagement perspective, that's been very interesting to me to have to address that despite the rise in the overdose numbers.
Thanks for mentioning that, Brooke. I was going to mention the communications campaign actually just initiated kind of a focus on fentanyl for that very reason. And something that kind of goes along when you're talking about distributing naloxone. We've had a big effort in trying to distribute naloxone and talking about the importance of having naloxone, even if you don't think you're taking an opioid, for all situations. And our team, and Brooke, you may have a better idea of what our number is, but I think we've distributed over 10,000 naloxone units as part of the initiative and many of the community-based organizations. And that's something, thinking about funding stream, talking about that we're looking for sustainability through our Kentucky opioid response effort core, as well as some of the additional dollars that have been coming through. So I know we have a key government official that is part of our initiative that so I'm just going to, even though she's not here, hopefully Katie Marks, I just feel like I need to shout her out because she does so much for us in trying to help with policy related issues, as well as kind of sustainability of the funding that we had for this initiative to be able to maintain that throughout our communities. But the other piece that you were talking about on take homes, that's actually an issue that we've been talking about within our policy work group, as the take homes have been extended right now, but there's the concern that we're essentially trying to make it permanent, but it's not officially permanent for Kentucky presently, but we certainly hope to do that. And I will also say, just since everybody was saying so many nice things about Vermont and Mr. Folland, I know we've never met, but we did actually meet with some members from the Vermont team to actually try to implement a new hub and spoke model within some of our communities where we had an OTP trying to get more buprenorphine out. It's from what we've heard, Vermont would be a great model that we would like to try to be able to implement here in Kentucky as well, to be able to expand and to sustain as well. But I think that I'm hopeful that with the new funds that just kind of came through the state, and as we continue to work with our key government officials, that may provide some additional opportunities to do those things.
Yeah, I think our struggle, Sarah, is what you mentioned. It's we treat, so if you look at kind of estimates of 1% of people have opioid use disorder past or present between ages of 18 and 64. We see that as an entirely underrepresentation of drug use, at least within New England. We currently treat, in the 18 to 64-year-olds, we treat about 2.5% of the Vermont population of 18 to 64-year-olds. In some of our communities, we treat as high as 4% of that age group. And we believe that we are treating about 50% of all the people who would be eligible for treatment, which is the highest per capita in the world that we can find, with the possible exception of France. And we know that that's probably 50, maybe 60% of people. And we experienced over the last 2 years the two highest spikes in overdoses in the history of Vermont. We treat, within our Department of Corrections, we treat 40% of anybody who's incarcerated, jail or prison, are on MAT. We have induction protocols in all but one emergency department, and that's such a small emergency department in a critical access hospital that there are two other hospitals within 8 miles of each other, that they just don't have enough volume and they don't have a quick off ramp. And we have it in every hospital's inpatient unit where we've seen cellulitis, infective endocarditis, or anything else. So our goal now is to try to do the outreach to those individuals who really we can't figure out how to get them engaged in care. We looked at past numbers. 70% of our overdoses are folks who have never touched our treatment system in any way. So it's not the folks that are coming in that are falling out of treatment. It's the folks that are still on the crescendo up, as far as we can tell, who haven't reached the point of decisional balance. And yet we know that about 50% of all the individuals coming into our treatment system have not crossed the Rubicon into injection drug use yet. So we're trying to figure out how do we get even further down the stream to those folks who we're not reaching. And yet every insurgence's attempt to get closer and closer to early prevention, early intervention. We've added on-site buprenorphine offerings at our needle exchange programs. both virtual and in person. So if somebody comes into our harm reduction sites and says, I want buprenorphine today, we are organizing buprenorphine instead. Somebody mentioned the challenge of fentanyl and its lipophilic nature of precipitated withdrawal. We're test piloting a couple of our emergency departments with ED methadone induction protocols with immediate outs to our OTPs. We have induction protocols on our inpatient units at 5 hospitals. The 5 hospitals most likely to have folks with infective endocarditis or the other, IV drug use sequelae. So we're trying to figure out, how do we do this, knowing the nature of the substance use is that folks have not necessarily come to a recognition from the data that we have within our state that they are actually ready to make that transition. But how do we expedite that transition, knowing that that's going to be a challenge? We're the second most rural state in the country, or first, depending on which metric you use, somewhere between us and Maine. We've got a new initiative where all of our OTPs will have a secure lockbox for up to 50 individuals that also has the ability for folks to video record themselves doing their daily monitoring, so we can still do daily monitoring of their medication. They would videotape themselves ingesting their methadone, so they don't actually have to be stable. For up to 50 people, the medication wheel will open once a day. They take their medication, they will videotape themselves. It uploads to the clinic, so we can ensure the safety of the individual in the community being unstable, but yet limit the amount of transportation time they need to make. If they have systemic barriers, we're trying to figure out, how do we do this well? And yet still struggling with, how do we find folks who are struggling with a chronic disease who may not be at the point of decisional balance to say that we want to address our chronic disease.
Wow, those initiatives in Vermont are, I don't know, causing me to salivate a little bit. That's pretty amazing. So I really, hats off, Tony. That sounds fantastic. So more on fentanyl. There's a question out of Delaware from Terry Horton asking about fentanyl. There has been a lot of chatter. I know that I have seen it clinically where folks are experiencing or reporting precipitated withdrawal beyond what is expected with buprenorphine induction. Have you been seeing it, Mike? What do you do about it if you see it? Have you been seeing it, Tony?
Yeah, we are absolutely seeing it. Some of the challenges, we offer walk-in services, and there was a time, just maybe, I want to say 4 years ago, probably 2018, where we started realizing how much fentanyl was getting in the community, and our clients had no idea what they were using, how much they were using, what really fentanyl was. And so we were reporting back, hey, did you know that you had fentanyl in your system? Oh, I had no idea. And we started seeing it then. We started seeing this back in 2018, where withdrawals were a lot more severe. We started seeing precipitated withdrawal with induction with buprenorphine years ago. It's been very challenging. Our wonderful docs have, come up with creative ways to try to address that. We have a triage, kind of an observation unit in our facility, which is fantastic, where we're able to, do different tests and different evaluations. Like the cows, we're able to see where somebody's at in withdrawal, give test doses, small test doses to see how clients respond medically. We're very fortunate to have the tool of methadone, where sometimes people, decide, hey, I no longer want buprenorphine, but I choose methadone. We also offer Vivitrol for those who may opt out of buprenorphine or methadone. We also have, a very large withdrawal management. We have 55 beds at detox, where we obviously have around the clock nurse practitioners and nursing staff, medical staff, and clinical staff and peers, where we're able to talk with clients who may be feeling uncomfortable. Unfortunately, our AMA rate is higher there due to some of these precipitated withdrawal factors and, just basically feeling crummy. One thing that this isn't a knock against Maryhaven. I love Maryhaven so much, but I think across the board in Vermont, I loved what Anthony was saying about some of the interventions in Vermont. Hopefully our state can, we're multiple years behind that, but we're getting there. I think we could do better with treating when somebody comes in and they report regular alcohol use, regular benzo use, regular barbiturate use. In a way, we kind of alter our treatment based on somebody's history of their use, and I don't think that that's appropriate. But I'm not a medical provider. I don't want to, pretend that I am or speak outside of my scope of practice. But I think across the board, we can do better with the legislation around methadone, but also our practice of buprenorphine induction and methadone based on an MOUD, based on benzo use and barbiturate use and alcohol use and fentanyl use. But it is really, really challenging. But this, we've been seeing the spike of fentanyl use for a long time. So just wanted to share those things. Thank you.
Terry, yeah, we're seeing it. It's sporadic, so it's not consistent. It's certainly not every individual who's taking fentanyl. Are we seeing them where it seems to be so lipophilic that they are then experiencing precipitated withdrawal with buprenorphine inductions? So we've kind of done a number of interventions. Some providers have moved to microdosing induction protocols, much smaller dosing over a protracted, a much longer period of time, kind of thinking through a 5-day period. One of our residential programs actually has seen a reduction in AMA discharges that way because to some extent they felt that it was almost patient expectation that once they at least got some meds on board and give a few comfort meds, that it actually met patient expectation that they were at least receiving some level of care rather than the wait for further induction, to kind of get to a standard induction protocol. We've got some outpatient providers, both in OBOTs, which we would call spokes, which I'm happy to define afterwards, or in OTPs, which we call hubs, that are doing induction-based protocols with microdosing. We have a couple of our OTPs where if folks want buprenorphine, which we still do, about 25 to 35% of our OTP inductions are on buprenorphine. So we will actually do like a 3-day methadone induction and then convert to buprenorphine because we won't take them over 30 milligrams, but we get them off the fentanyl and then can make a very, much more simplistic transition to buprenorphine if that's the better medication and the shared decision-making model. So there's some strategies that we employ depending upon setting that we've been able to use. And that's the other reason that we're going to be adding and have started to add methadone-based ED induction protocols for those folks where we have experienced either precipitated withdrawal in the emergency department or individuals who are afraid of experiencing precipitated withdrawal in the EDs.
Yeah, I think that's a great. I just had one kind of comment for Art, where it was, of course, working with these communities, we're not hearing directly from each individual patient, but what we are hearing is from the providers that we in the community agencies that we're trying to work with. And if for Kentucky in particular, what we found is we were communicating with a lot of our emergency departments was just a lack of protocols for ED initiation of buprenorphine, and even far less so for methadone. We have one community agency that will initiate with methadone. And so part of our attempted effort was really even just getting induction protocols in general. And then this kind of the same principle we have provided to try to provide some tailored protocol assistance in working with, finding out who are kind of like the leads that can help create a change. And then in creating we've had two community agencies that did kind of follow back up with us and using the induction protocol and provide some tailored assistance around microdosing, similar to what your experiences have been. But I would say in our case, for where we are in our state, it was really just trying to get induction protocols and treating, inducing at all sometimes is an issue. Sometimes even treating with comfort medications has been an issue in our emergency department. So I feel like we're unfortunately so far behind that we're just, only a couple of our hospitals are even getting to this notion of microdosing or using methadone instead, from what our experience in the hospital. But that's what we're continuing to see progress, especially now that I think there has been some additional ED discussions recently as the staffing hasn't been as detriment throughout the pandemic. But I still think we have kind of a long way to go from what we've seen in our communities in Kentucky to kind of address some of those concerns.
Thanks to all of you for your perspective on this important issue. I can say that in Pennsylvania, fentanyl, I think started coming around 5 years ago. And clinically, I started noticing that people were not tolerating buprenorphine inductions in the same way that they were before. And I needed to start most of these folks on methadone right away. But I do know that nationally, this is a controversial issue, that there are some people that just don't think that this is a problem, that, it's word of mouth or it's perceived fear, not actual fear. But, I think that there are variations geographically on where fentanyl is, and then what fentanyl we're talking about may be of issue as well. If we don't know what analog we're dealing with, or if one is more amenable to buprenorphine induction than the other. Either way, it certainly warrants further study. And I know that several investigators, including myself, are cutting their teeth into this issue to sort out issues like, can microdosing be practical in the outpatient setting versus high dose inductions, which may be a little more practical with comfort meds in addition. So, but super critical question, comes hand in hand with different ways of and different milieus for methadone induction, such as emergency departments, possibly pharmacies, different ways to access methadone, and ultimately would come down to another act of Congress, but that is a lot to take in. So we have one more, Tony, did you have something else you wanted to say? Okay. We have a question also, will treatment facilities continue telehealth in the aftermath of COVID? I can tell you from our treatment facilities perspective, yes, we're going to do that for as long as we can. A lot of it, we're kind of hamstrung by our state's legislation on it, but we can use this time period to get our license updated so that we can continue telehealth. I don't know if that's anybody else's experience.
We've long allowed telehealth as a state. We have a reimbursement mechanism for telehealth. We done telehealth forever. I think the shift will be back to really the clinical matching of when is telehealth appropriate versus when would somebody need to be managed and seen in an office-based setting. That we've kind of gone from one end of the spectrum to the next, and now we'll be able to use some critical clinical decision making on when is it most appropriate and how do we do this well is really the goal that we're looking for.
Yeah, I second that. We have the opportunity to work with client preference, where our therapists and groups we have hybrid models for almost every program. We have the ability to offer telehealth, Zoom, in person, if clients choose to come in, which is great, and just like Anthony said, we have been able to do in the state of Ohio, been able to do telehealth and telemedicine. We just never did. For us, it wasn't part of our workflow, but we had to pivot, and now everybody is supportive of ongoing telehealth and telemedicine. And thank God, thank goodness the bureaucrats listen, to the constituents, because now we're seeing getting written into rule for the Counselor and Social Work Board, the Ohio Chemical Dependency Board, Board of Pharmacy, you name it. But there still is, I don't know, SAMHSA should listen, but for methadone induction, it still has to be in person, which is ridiculous. So obviously that stigma still persists, but every medication, buprenorphine, Vivitrol, you name it, but for methadone, it initially has to be a face-to-face. That has to change. So just wanted to throw that out there.
And the only thing I have to add, since, of course, we're looking at our community partners, so a variance across where we're not built a specific network to say, oh, yes, we're definitively, but I think what we have seen in terms of the policy work group is making such a difference for some new agencies to provide telehealth-based services is when they enacted, in Kentucky, the ability to just be reimbursed at the same rate as in person. And that's when last year in 2021, that's when a lot of places started increasing. And so our expectation, even though we don't have a set, that I can say for certain, so many are going to sustain, was that would develop the sustainability model to be able to do that through the reimbursement. So I don't know, it's certainly our hope that many of the places that have started to offer telehealth services, for buprenorphine, as well as a lot for the mental health benefit. We've seen a lot of new services to be able to treat the co-occurrence of mental health issues through telehealth. That I would hope we'll see continue and maybe see more community partners that we can work with as we move into our Wave 2 counties as we continue with our study.
Yeah, I mean, I can say from personal experience, it's actually pretty nice to see where patients live, meet their pets. Sometimes I get to meet their kids, spouses, and it really is just a great, way to center the patient, especially if they're more comfortable at home. And so, I hope this is a positive change we can see in the future. In our last 2 minutes, we got an important question that was asked. Where do you think the research priorities lay regarding treatment, particularly with access and retention focus?
I just want to share, Maryhaven, super supportive of research. We were one of the original sites where we tested the efficacy of buprenorphine induction for people in withdrawal versus clonidine back in 2003. And that's one of the reasons, that we have buprenorphine as it is today. Research is extremely important in all aspects. Cannabis research as well. I think we have to lift that the stigma off more research for cannabis as it relates to every ailment. Research is extremely important, and my hope is that the funding and agencies that are participating in here in Penn State and the CSUA continues to support research across the country. So very, very, very important.
I would just say from our perspective, our communities have wanted to focus a lot of the efforts in this study around those EDs and then criminal justice. And as Chris mentioned previously, I think Kentucky's probably behind in a lot of ways, but really trying to figure out how we can reach more populations with that induction process. So that would be, from a community perspective, what I have really seen from our stakeholders that they would like to see increase.
Yeah, thanks. And I'll take on the retention piece. So I would say for us, Brooke mentioned that one of the major initiatives that we've tried to launch throughout the study is embedding peer support specialists and nurse and social work care navigators through our community partners. And some of those are in high risk venues to link to treatment, like our syringe support programs and some of the criminal justice settings, probation and parole, and things like that, or some of our criminal justice agencies that aren't actually allowing us to treat with MOUD within the criminal justice settings themselves. But then we also have a significant amount that are focused in working with the OBOTs and other places that are providing the buprenorphine treatment. And a lot of the work that we've seen in those cases are being able to establish those relationships where sometimes the navigator or the peer is the first thing to kind of hear about an issue that then they are able to support and encourage, or have an ROI to speak with the provider, as well as the use of those MOED barrier relief funds that Brooke was mentioning that have helped so much with a lot of the psychosocial aspects of remaining in care. And so one of our initiatives is, of course, to look at this model that we've implemented and see the impact on retention rates. And then hopefully, if it's anecdotally successful right now, we wouldn't need to run the actual results, and if so, of course, then be able to disseminate that information about the program to try to allow others to use that and see an increase in retention rates.
And I would defer to Sarah, because clearly Sarah is much more of a researcher than I am. For full disclosure, I'm on the community advisory board for the New England, the node out of Dartmouth for the Clinical Trials Network. For me personally, I think the research, my hope anyways, is the research moving toward treatment matching and looking at not just medication. We've done a lot of look at medication of methadone versus buprenorphine, but really looking at treatment structures. If I think of things like the old adage of there's two ways to make people incompetent, ask too much or ask too little. There are some people that are going to do extraordinarily well in low barrier type programs, which is really the discussion that we are having now. But there are also those individuals who that will be an insufficient structure and who will struggle. There are those individuals whose retention rates are very high, attending daily dosing of methadone. And there are those folks that burden is too high and we lose them. But we don't have a great sense as a field as to whom are those individuals and how do we match them, any more than do we have a great sense of who are the folks that are going to do really well in a predominantly telemedicine world versus those folks who need the structure and the human connectivity that is much more of a face-to-face visit. And how do we get down to some of those treatment matching structures that really go from the research to kind of the devil in the details of research for me?
Well, thank you all so much for your contribution for this crackling hour. I would say that, retention and treatment is the golden question, and it's something that we always need to be thinking about because it is a proxy for survival, and we need to definitely lower our barriers of entry and compete better with drug dealers. We just need to be more prevalent and cheaper and safer and better, and figure out cleverer ways to get people into treatment and meeting people sooner on the treatment continuum so they can't die. But thank you so much to everybody participating in this panel. I'm sorry we ran a few minutes over. There will be a lunch break, and this will continue at 1 p.m.